We are live.
Okay. So good evening, postgraduates, and welcome to this 66th episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. Today is the 66th episode of the series, and today we are going to have a didactic lecture on principles and techniques of lead reconstruction, which was a long question for one of the MS finals. Today's didactic lecture would be presented by Dr. Adit Gupta, who is an oculoplastic and orbit surgeon from Mumbai, and he is with Max Nanavati Hospital, Mumbai, as well as visiting consultant at Nayar Medical College. Also, my special thanks goes to all the discussants, Dr. Vatsalya Venkatraman, who is a consultant oculoplastic surgeon at ASGI Hospital, Jodhpur, Dr. Anuradha Iyer, who is an oculoplastic surgeon and founder of Oasis Care Center, Thane, and Dr. Aka Chatterjee, who is a senior consultant at Sushrut Eye Hospital, Kolkata, for consenting to be discussant. So without much ado, can I request Dr. Adit Gupta to share his screen and let's move ahead with the presentation.
Yes. Good evening, everyone. I hope my screen is visible.
Yes, Adit, please.
Okay. Thank you, Dr. Prashant sir, Dr. Kasturi ma'am and team AIOS ARC for this wonderful initiative where everyone is given a platform to share their thoughts and in a way sort of modulate minds of young postgraduate students. Now, as Dr. Prashant sir mentioned that we have to understand the concept. Once you understand the concept, writing a long answer becomes very easy. It flows through your mind, right? So for postgraduates, I've broken down this topic into understanding the concept behind eyelid reconstruction and then quickly going through case scenarios so that you have it vividly in your memory when you sort of think about writing this question. Now, I would like to acknowledge my past alma maters because some of these pictures and cases might be from my fellowship training days. Now, as we all know that eyelid defects can happen because of multiple causes. The most common eyelid defects that we encounter in practice are mostly post-traumatic, where there is an eyelid avulsion or tissue loss. Second most common is during an eyelid malignancy excision, where there is a contraction or necrosis of the eyelid tissue. It could be because of infection, radiation, or chemical injury. And many times you also see eyelid defects because of congenital cases. Now, why eyelid reconstruction is important? When I go back to my early practice days, this gentleman, young gentleman, was one of my first patients in private practice. He was just 30 years old and he had undergone multiple eyelid reconstructions from all possible surgeons, plastic surgeons, maxillofacial surgeons, and had ended up like this. Now, what you can see on the left-hand side is an eyelid with no support, with no structure, with no function, and no cosmesis, obviously. You can see an inflamed ocular surface. He's not using his eye at all, and he was all very troubled by this appearance as well. Now, before diving into the principles of eyelid reconstruction, anatomical knowledge is very important. The eyelids are very intricately packed structures, and the upper and the lower eyelid both consist of anterior and posterior lamella. So basically, it's a bilamellar unit where the anterior lamella is formed by the skin, the muscle, which is orbicularis oculi muscle, and the fat. And the posterior lamella, which is basically the skeleton of the eyelid, comprises of the tarsus and the wet surface, that is the conjunctiva, and all the accessory lacrimal glands and the meibomian glands that come into play within the tarsus. So you need to know this and remember this very well, because this is what is going to form your basis for eyelid reconstruction. The orbicularis muscle, which is the main protractor of the eyelid, is basically a very vascular muscle. It comprises of three parts: the pretarsal part, the preseptal, and the orbital part. All three of them are important since it is very rich in vascularity. It helps us in eyelid reconstructions because usually there is never a dearth of blood supply in eyelid tissue. The pillars of the eyelid are the medial and the lateral canthal tendons, which basically provide the anchoring support at either end and help supporting the eyelid and keeping it taut. So these structures are also important because if during an eyelid reconstruction you encounter these structures, you need to replace them with like. Now, we all need to remember that the eyelid has dual supply, both from the internal as well as the external carotid artery circulation. And if you see, the majority of the eyelid blood supply comes from the marginal arcade, which rise at the tarsal margin. So this is a very important source of blood supply, which you need to maintain during an eyelid reconstruction. And any blood supply from this usually is enough to survive for your graft or your flap. Why nerves around the eyelid are important? Because you can perform around 80% of your surgeries by using these nerve blocks. The most commonly used is the infraorbital nerve, which anesthetizes almost the lower two-thirds of the eyelid. The supraorbital nerve, which anesthetizes the medial one half of the eyelid. The lacrimal nerve or the zygomaticotemporal nerve, which you can help in getting anesthesia for the lateral canthus, along with the zygomaticofacial nerve. So these nerve blocks are very important as they help augment the effect of the anesthesia and give you good comfort during a local anesthesia surgery. I would skip about this part because this is more advanced. Lymphatic drainage is also important because whenever you cut the eyelid tissue, you expect a little bit of lymphedema, but we don't discuss too much about this. Now, coming to the functional indications or functional considerations during an eyelid reconstruction. What is the aim of eyelid reconstruction? If we follow a step ladder approach, the most important aim is to protect the eyeball and to restore function. That is, they should blink, they should spread the tears and the oily secretions of the meibomian glands over the ocular surface so that you have a good uh, tear meniscus film and tear meniscus height. Second important aim is to restore mobility, that is to blink and to provide retraction and protraction of the eyelids. Have a stable eyelid margin so that the meibomian glands can function properly and you have a crisp tear meniscus. And last but not the least is cosmesis, which is also gaining importance now. Every surgery that you perform has to have good cosmetic outcome as well because of awareness which has increased amongst people in general. So if you follow a step ladder pattern, first you should aim at function restorement, visual restorement, and then cosmesis. Now, there are certain basic principles that we have to follow while performing an eyelid reconstruction is the principle of lamellar reconstruction. Lamellar reconstruction means you replace anterior lamella with anterior lamella-like structures, posterior lamella with posterior lamella-like structures. That is like for like. There should be adequate horizontal tension, no laxity, otherwise it might lead to eyelid malpositions, either in the form of entropion or ectropion. And last but not the least is whether you're going to use flaps or grafts. Now, a combination of flap plus graft or a flap plus flap works better. Remember, you can never use a graft on graft because it doesn't have its own independent source of blood supply, and these cases are usually most likely to fail. So this is the most important part that you need to know, that you can never sandwich a graft over a graft. It should be either a flap over a graft over a flap, or a flap over a flap. Choice of procedure which we perform depends on the extent of defect, the status of the remaining tissue, the visual status of the other eye, whether the patient is one-eyed, age and general health of the patient, and the surgeon's own expertise or preference for a certain procedure that you discuss over a period of time. Surgeons become more comfortable with certain procedures which work better in their hands, and so they choose those procedures. Now, again, there is a pyramid that can be followed while performing eyelid reconstructions. Healing by secondary intention, direct tissue closure depending on the extent of the defect, and using skin grafts. And if the defect is too large, you sometimes have to refer the patient to a general plastic surgeon for a free tissue flap, which have to be harvested either from the pectoral muscle or the latissimus dorsi. I follow a very simple algorithm whenever reconstructing the eyelids. Usually, the eyelid tissue is very good, very forgiving. And if you look at the face, it has different subunits arranged in different patterns. There are prominent landmarks in the form of eyebrow, eyelid, the nasal tip, the medial canthus, the lateral canthus. So what I do is basically analyze the defect with respect to skin loss versus tissue loss versus the posterior lamellar loss. Follow the reconstructive ladder, which I just discussed about. Keep an anatomical landmark which you want to replicate. So you can replicate it with the other eye. You can keep the nasion or as a glabella as a landmark, and then follow and build up your eyelid tissue. Follow the incisions in the relaxed tension skin lines as you see here, as the healing is the best in these when the incisions are hidden in these lines. And as you see on the upper eyelid, they curve upwards, and the lower eyelid, they curve downwards towards the cheek. And then keep in mind about any medical condition like previous radiotherapy, diabetic patient, or a patient with DVT or vascular insufficiencies. Now, coming to the next part of this, this is a very, very good paper which has been published by Raman Malhotra's group, where the eyelid reconstruction. So this one screenshot, or if you can remember a part of this, if you draw it in your answer, it will just make the understanding for the examiner also very clear. Just seeing at this diagram, they know that this student knows quite a bit about eyelid reconstruction, and they won't read too much of the theory that you write down. So if you can build this small chart which is incorporated here as to how to approach an eyelid tissue, it would be very good. How I'm going to proceed ahead is show you how this chart is formulated. So now let's divide the eyelid reconstruction into two parts. First is an isolated anterior lamellar defect, that is a skin muscle defect, and then go on to full thickness defects. Now, an isolated anterior lamellar defect usually is involving the skin and the orbicularis. It can heal by primary closure, secondary intention, skin graft, or a myocutaneous graft. The best way to deal with primary anterior lamellar defects are by closing it using flaps, because the eyelid skin is lax and surrounding there's a lot of tissue available. Healing by certain healing is certain areas like the medial canthal region sometimes heals very well just by leaving it apart, but that you should think about only in patients who cannot undergo surgery. Now, myocutaneous flaps are always the best way to reconstruct an eyelid tissue or any tissue as on the whole body, because they are perfect match skin color matches to each other. It's locally available, rich blood supply, and innervation of the nerves, and healing is faster with least contraction and excellent function. Second, that we can use is skin grafts. Now, usually around the eyelid region, we mostly use full thickness skin graft. So if anyone asks you a question in the exam, what graft would you prefer for the eyelid tissue? It should always be full thickness skin grafts, except where we use for exenteration defects, where a split thickness skin graft can be used because it survives better on the bare bone. So if anyone asks you what graft would you use for an exenteration defect, it's a split thickness skin graft. While other all eyelid defects are full thickness skin graft, which can be harvested mostly from the pre-post auricular area or the supraclavicular region. Now let's come to clinical scenarios. Now look at this defect. This I've picked up from one of the textbooks. This is a defect post-excision of a xanthelasma. If you try to close this directly, sometimes an eyelid malposition might remain, or you might get a webbing of the medial canthus. So here a locally advanced hinge flap has been used, and this area has been advanced medially, and this defect has been closed. Similarly, if you look at this basal cell carcinoma in this elderly gentleman, it is involving the lower lateral part of the eyelid. You can see a classical features of basal cell carcinoma. Usually you keep around 2 to 3 millimeters margins around the diseased tissue. And if we were to close this defect directly, it would lead to malposition of the lower eyelid and an ectropion or a lower eyelid retraction, which would not be the best thing. So in such cases, this is just an anterior lamellar defect. The tarsus is not involved. You perform a rotation flap in the form of a modified Limburg's flap, where you sort of dissect the surrounding tissues and then transposition these tissues so that there is no vertical pull on the eyelid. So if you see that the vector of the pull is along the axis of the eyelid, along the horizontal axis and not the vertical axis, and the suturing also doesn't exert an extra pull on the lower eyelid, and you see the position of the eyelid is very well maintained. This is the result after 1 year. So this is called as a Limburg's flap, where a round defect is converted into a rhomboid, and along the short axis or the long axis, depending on what type of flap you're using, you can transpose these tissues very well. This is another example of how a Limburg's flap or a rhomboid flap can be used for reconstruction of the eyelid. Now, coming to full thickness defects, these are defects where the eyelid is completely sort of lost, where you lose both the anterior as well as the posterior lamella of the eyelid. More commonly seen in patients of trauma, or sometimes in patients who have undergone surgical excision of malignancies. For ease of purpose, I have divided these defects into 4 parts. We'll deal with defects of the upper eyelid, defects of the upper eyelid along with the medial canthus, upper eyelid with the lateral canthus, and then lower eyelid simultaneously, and then some defects which cannot be closed just by Now, we all know that direct closure of the eyelid is possible since the eyelid is lax, especially beyond the age of 40 to 50 years. Up to one half of the eyelid can be closed by direct closure. And in this, we follow very simple principles of tissue approximation. The first suture, usually according to textbooks, should be taken at the gray line. The gray line is nothing but the line where the meibomian gland orifices lie. And in a mattress fashion, the sutures are taken, and then the when the suture is tightened, you should see that there should be pouting of the edges, because as the tissue heals, this pouting resolves and the eyelid becomes smooth. So when the healing, if at the end of surgery you notice a flat line, then certainly you're going to develop a small notch. So first thing to remember in direct closure, use first suture at the gray line, second suture at the anterior lamella, and then you start closing the defects. You may choose to close the tarsus separately, or you might directly close the skin as well. And then there should be a pouting of the eyelid margin when you are getting off the table, so that the eyelid margin becomes flat as the healing proceeds. This is an example where we perform a pentagon excision. This is a very large papilloma. This is pedunculated, so from below you can remove. And then a direct closure has been performed. At 1 week, you can see that the eyelid margin is straight and healing well. Now, when you're thinking about full thickness defects, I always think of it as an ice cream which is sandwiched between two wafers. So you need to sort of reconstruct these separately. So you need to break down those defects. Think about how I will reconstruct the tarsus. Think about how I'll reconstruct the skin, and then everything falls into place. Now, these are some cases which I had performed with my mentor during fellowship. You can see that this lady has an upper eyelid medial lesion. This is a malignancy. So you see that 2 to 3 millimeters of margins are kept, and you're left with almost just a little bit of the lateral part of the upper eyelid, and almost like a full thickness defect. You can see a little bit of the medial fat pocket also showing here. The punctum is already gone, but the lower canaliculus is intact. Now, in such cases, you need to first think how you're going to reconstruct the tarsus. Now, tarsus can be reconstructed in such cases either by taking cartilage grafts, which sometimes are not very good because you have to perform a sandwich graft, but a cutler beard graft in the form of tissue from the lower eyelid goes up and replaces the posterior lamella. Sometimes you can divide the cutler beard graft into two and then suture it separately. And then the anterior lamella can be rotated in the form of a glabellar flap, which covers the medial part of the defect. So this part is taken care of by the glabellar flap. And thus the defect here is being taken care of by a cutler beard flap. So this is how a upper medial defect can be reconstructed. This is how, if you follow algorithm-wise reconstruction, you can get very good outcomes. Now, coming to upper medial localized defects. Now, this defect is not that big. After excision, you see that the 50% of the upper medial eyelid is left. Now, here you have the tarsus, almost 60% of the tarsus left, which you can use to fill the posterior lamella. So a sliding tarsoconjunctival graft can be used. Here, a sliding tarsoconjunctival graft is being used and is being transposed to fill the posterior lamella. So if we stop here for a moment, we see that the posterior lamella is well formed and sutured here. Now you need to think about how you're going to reconstruct the skin over top of this. Now, if you look closely, you see a lot of wrinkly skin here, which can be harvested by performing a blepharoplasty, and the same skin can be used to fill this defect. So this is how creative you can become while performing eyelid surgeries, which is why it is a very exciting surgery to perform. Sometimes the defects might be very small, innocuous, but you might see that when you spread them, this defect almost doubles in size. Secondly, you have to reconstruct the medial canthus, which is one of the most challenging areas to perform. And thirdly, you also need to see if some part of the canaliculus can be reconstructed. Canalicular reconstruction is not very difficult to perform. Every one of us knows that mini Monoka tube works very well. And this is just a small clip to understand how canalicular reconstruction is performed. After good punctal dilation, you find the cut medial and the lateral end of the punctum. Here you can see that the punctum dilator has come out through the medial end. And then you insert a probe to just get a sense of the direction of where the cut end of the canaliculus would be. Now, there are different ways of identifying the cut end of the canaliculus. The most common is under high magnification. You can see a round, whitish, pale ring. Here you can see that this is the ring of mucosa that you can easily make out under high magnification. The other ways are using a drop of adrenaline to vasoconstrict the mucosa, or sometimes using a dye through the lower canaliculus to get fluid out of the cut end of the canaliculus. Once this is done, you confirm a hard stop. You do syringing to confirm, and then you can use a silicone mini Monoka tube to sort of approximate the canaliculi and perform canalicular reconstruction. So see this, the mini Monoka tube is being inserted through the cut end, and then gently it is being threaded into the sac. And once that is done, the medial eyelid itself falls into position, and then pericanalicular suturing is done, and then the skin defect is closed. So you get very good results, especially once the mini Monoka is put, the medial canthal anatomy also forms and sets into place, and you get very good architecture of the medial canthus as well. Similarly, upper eyelid defects can be reconstructed in the same way. Now, from the upper eyelid, let's shift to the lower eyelids. A nodular sebaceous gland carcinoma, this is a spot diagnosis. Once you see, biopsy can be done, or you can directly go ahead with wide local excision. So in this elderly gentleman, we did a pentagon excision along with 3 to 4 millimeters margins. I prefer using frozen section for intraoperative sort of control of margins. And then you can see that although it looked very small, the defect now covers almost 60% of the lower eyelid. Now, in elderly people, especially above the age of 60, the eyelid tissues are very lax. So these defects can be very easily sort of filled up by performing a canthotomy cantholysis and a local flap in the form of a Tenzel semicircular flap, which we did here. So before reconstructing this defect, you can see once I pull the eyelids with the help of stay sutures, the defect you get an idea of how much you will get just by pulling the eyelids, and then performing a flap will give you the remaining sort of pull needed to approximate the two margins. So a Tenzel semicircular flap is performed. Here you can see that the skin is undermined, a lateral canthotomy is done, cantholysis is done, and then after undermining this, a small incision is made here, and this tissue is then advanced here, and then the eyelid is sutured. Now, Tenzel's flap is a very important flap, which as postgraduates, you can be asked about because it's a locally based flap and it can be used for the lower eyelid reconstruction as well as upper eyelid reconstruction and provides good vascularity and outcomes as well. Second flap, which you should be knowing about, at least in theory, is the Cutler beard flap. Now, the Cutler beard flap is basically a flap which is based on the lower eyelid. This is a classic flap which is based where it's also called as a bridge flap or a sharing flap because you're using the lower eyelid tissue to reconstruct the upper eyelid. What you should know about the Cutler beard flap is that it requires two stages. You need a second surgery, a smaller surgery to sort of divide the flap so that the upper eyelid becomes the upper eyelid and the lower eyelid becomes the upper eyelid. It is used in cases where the upper eyelid defect is more than 60%, or before that you can use the Tenzel semicircular flap. So here you can see that a Cutler beard flap is used, and this is the bridge that you see. So the marginal arcade gets blood supply to these parts, and that is why the bridge also survives and the flap also survives. The flap gets its blood supply from these parts. And then once the division is done, you can see very good approximation. There's a little line that stays here because that is where you suture because of the lymphedema, but then you get very good results. Eyelashes are not present, unfortunately, and sometimes some patients do experience a little bit of trichiasis because of the lack of tarsal architecture in these flaps. Now, similarly, if we go to the next part, upper eyelid, lateral part, now here you don't have any tissue left. You can't use tarsus. So you need to take either tarsus from the lower eyelid or you can take periosteum from the outer corner of the canthus. And this, if you see, little bit of periosteum from the bone has been taken and converted into a flap, and this is sutured to the tarsus. Above this, the anterior lamellar reconstruction can be done in the form of an advancement flap from the canthus or the temporal region, or then various other flaps can be used. In this case, we performed a Cutler beard flap along with a periosteal flap. Now, I wanted to show this picture to you especially because sometimes in exams you can be asked about frozen section or Mohs micrographic reconstruction. Now, frozen section is a technique which we used in India where intraoperatively, when the eyelid tissue is sent for reconstruction, these margins are then studied under rapid pathological tests. They are subjected to frozen ultra high, ultra low freezing temperatures, and the pathologist can tell you whether a malignant cell is present in these margins so that you can revise the margins. Mohs micrographic technique is basically more so done in the US, where without frozen section, they just directly take sections and it can be done in a three-dimensional format. So Mohs micrographic is more superior to frozen section if anyone asks you in the exam. And this is how, with the cutler beard flap, we can also reconstruct the lateral canthus as well. Now, coming to huge defects of the eyelid, where the whole of the lower eyelid along with the medial canthus is involved, and you're left with almost no eyelid at all. For such cases, you can use flaps which are based on the forehead. So, median forehead flap can be used and it can be rotated downwards and then can be used to reconstruct the lower eyelid. But this is a very advanced flap which sometimes needs more training to be done. Similarly, lower eyelid can also be reconstructed by using a reverse cutler beard flap from the upper eyelid or a trapezius flap, which is based on a hinge of the upper eyelid and it can be got down. This is a trapezius flap where the upper eyelid bridge is brought down and sutured on the lower eyelid. Now, coming to the last part, one flap which we have not discussed about, which is commonly asked about or which can be done very commonly, is the Hughes flap or a tarsoconjunctival flap from the upper eyelid. Now, this young lady was being diagnosed as a chalazion and had undergone a INC as well, which was dry. And then after biopsy, it turned out to be a sebaceous gland carcinoma. So after excision, you can see that this defect is almost involving the lower 50% of the lower eyelid. The bony rim can be seen, little bit of the fat is visible, and this is the orbital rim that is visible. Now, to reconstruct such eyelids, you need to sort of take some we will demonstrate tissue from the upper tarsus as well, because the lower eyelid is more sort of dependent. If you don't give it structural integrity, then it is going to either turn into entropion or ectropion. So after taking stay sutures and after excising the defect, you see that this is the defect. A double freeze thaw cryotherapy is performed. Now, this is the periosteal flap that we are harvesting. You can see that this is the periorbita, which I am excising, and this periosteal flap is then removed. And this is the tarsoconjunctival flap I was talking about. I'm just showing a quick video to show that the upper eyelid tarsus can be transposed to the lower eyelid. This is the upper eyelid tarsus. You keep around 4 millimeters of tarsus for stability of the upper eyelid, and the remaining tarsal tissue, along with the conjunctival vasculature, can be taken down and transposed down. So releasing incisions have to be made so that it can stretch and not be under too much traction. And the end point is usually when it rests in position. After this, this is sutured to the remaining tarsus on the lower eyelid, and on the lateral end, it will be sutured to the periosteal flap, following which the fornix is sutured onto the lower edge of this, and then skin graft or a flap from the upper eyelid can be transposed. Here we are using skin from the upper eyelid in the form of a monopedicle flap, where the flap from the upper eyelid is transposed to the lower eyelid. You can see that this flap is transposed down. So you can get very good outcomes with these flaps, local flaps, especially Hughes flap, which can be used to reconstruct the lower eyelid for the tarsal part, and the anterior lamella can be used either via skin graft or with a monopedicle transposition flap from the upper eyelid. Not always everything looks so rosy. Look at this elderly gentleman where the basal cell carcinoma, you can see, has almost eroded the medial canthus, the caruncle, and has gone in deep, infiltrated the medial orbit as well. But on CT scan, it had not sort of eroded the bone, and the patient was very vehemently denying an exenteration. So sometimes you can go ahead and do extensive debulking and be left with almost nothing. Here you can see the bone of the lacrimal crest. This is the anterior lacrimal crest. The sac was removed. You can see that the caruncle has been debulked. The upper eyelid is almost 50% gone. The lower eyelid is 70 to 80% gone, and you're left with a huge defect. Now, in such cases, it's almost impossible to recreate a normal eyelid, but sometimes you can use flaps, as I showed before, and hinge them and sort of try and get something there in place so that the eyelid can at least close. And this is what we achieved in this. So it's not always impossible to do this, but the most important thing is you have to keep a watch on recurrence, because malignancy has to be treated first before cosmesis, function, or salvage of the eye. In this case, it was a BCC, which is not very aggressive and not metastatic. So we took this chance, and the patient is doing well at 2 years of follow-up. Now, one thing which I would like to say is that every surgery has its own complications. Complications can be in the form of, especially in eyelid reconstructions, could be in the form of bruising, eyelid notches, entropion, ectropion, trichiasis, wound gape, uh, because when we are suturing the eyelid tissue is under a lot of tension. Sometimes when we are trying to close it directly, especially any form of infection or poor healing, can lead to wound gape as seen in this patient. So in this patient, I had removed this tissue after performing a biopsy. This was the defect, not very big, but it was a 40-year-old young patient, and he ended up on day 7 with a wound gape. So you see, this is not a good sign. You can see that the eyelid tissue has retracted completely. There is necrosis at the edges. So I don't know what was going on, but maybe an infection which led to the wound gape, or maybe the eyelid tissue was under too much tension. But at this moment, what I would reiterate is, as any clinician, students, you just need to follow your basic principles, follow your gut principles, follow the principles of anatomy and physiology. And then what we did here was we just took a tarsoconjunctival graft from the upper eyelid, transposed it down, and then used a skin graft. So now a flap was not possible because the tissue is already sort of necrosed, and doing a flap in this case would not help our cause. So we did a flap from the upper eyelid to get the vascularity and a little bit of skin graft on top of it, and then we can salvage some part of the eyelid. It looks a little nodular, but still form and function has been maintained. So to summarize, eyelid reconstruction, I would say that first and foremost, you should know about the eyelid anatomy. You should know that you can invent and reinvent any structure if you follow your basic principles of surgery, and uh, pathophysiology is well understood of the disease. You should never perform a graft over a graft because the graft doesn't have its own vascularity. You have to sort of measure the defect. If the defect, a rule of thumb is in the eyelid, depending on the age, if the defect is less than 30-40%, a direct closure is possible. Between 40 to 60%, you can get away with a direct closure along with a canthotomy, cantholysis to pull a little bit of the lateral part of the eyelid. Beyond that, you might have to use a local flap in the form of a Tenzel's flap. Beyond 60%, you have to use either a flap, a skin graft, or some of the local eyelid sharing techniques. I usually always, whenever I am demonstrating training or anything, I always prefer flaps over grafts because I think the cosmesis along with function is always better. But sometimes if the flaps are not available, or if the local tissue is diseased, you have to resort to skin grafts. In the eyelid, full thickness skin grafts are always preferred over split thickness skin grafts, except in accentrated sockets. And whenever you perform an eyelid defect, or if you're assessing an eyelid defect, you should have plan A, B, C ready, because sometimes plan A might not work if the defect is not, if the eyelid tissue is taut, or if it is diseased, or if you end up with less tissue, or if there is too much of cheese wiring of the sutures, you need to have a plan B or C in place. And always, if the defect is too large for you to manage, you always have your friendly plastic surgeons to help you out with free tissue transfers or grafts from somewhere else. Thank you. If there are any questions or any points, I would invite the discussants to please give their inputs from the postgraduate point of view. And I am open to any questions or discussion if needed.
Thank you, Dr. Adit, for that comprehensive and such a well illustrated talk. You showed such excellent clinical photographs and walked us through the salient steps of surgery so expertly. Thank you so much. And you also demonstrated not only the structural, but also the functional and the cosmetic aspects of lid reconstruction. So with that, we move on to the discussion. And we have with us Dr. Vatsalya Venkataraman, who's an oculoplasty consultant at the ASGI Hospital, Jodhpur. Dr. Anuradha Iyer, who's an oculoplastic surgeon and founder of the Oasis Care Center at Thane and also works at the Jupiter Netralaya at Thane. And Dr. Raka Chatterjee, who's a senior consultant at the Susrut Eye Foundation and Research Center at Kolkata. So thank you so much for being here. And I start with Dr. Vatsalya. So would you like to add something, any pointers for the PG, the salient points that are generally asked in the exams and they should be aware of, if you could just summarize?
Yeah, so good evening. Actually, Dr. Adit has elucidated all of the relevant points as far as PGs are concerned. I just have one question though. Sir, would there be any bearing to the suspected etiology of the excision of the lesion that we are doing on the possible reconstructive measures, especially on the lines of a lid sharing procedure? In your experience, have you seen that etiology has any bearing?
So, I know means usually some people there is a certain school of thought which says that you should try and avoid lead sharing procedures as much as possible, especially in sebaceous carcinomas or melanomas, or even squamous carcinomas, because whenever you do a lid sharing procedure, and if there is a sort of a local recurrence, you are sort of sharing the upper eyelid with the lower eyelid or vice versa. So you're directly transmitting diseased tissue from the upper eyelid to a non-diseased part. So there are schools of thoughts, but when especially in cases of sebaceous carcinoma, when you're left with no tissue at all, and if I would want to prefer sort of a Cutler beard flap or a Hughes flap over a Mustard's flap, I would go with a Cutler beard or a Hughes, because if I'm sure that I've removed adequate tissue and adequate diseased tissue and I have frozen section, then I would sort of worry about form and function more than a recurrence. But certainly, yes, if you know that you have not got adequate margins, you should try and avoid sharing procedures, because then you're directly transmitting a diseased tissue to the healthy margin as well. In cases of melanomas, where you are supposed to sort of keep more than 8 millimeters margins, you're not left with much tissue as it is. So you might have to take Mustard's flap, especially for the lower eyelid, or a flap from the eyebrow for the upper eyelid. So their lid sharing procedures as it is might not be indicated if you have lost the whole eyelid.
Right, sir. Another thing that I just wanted to take a note of is that in situations wherein, let's say, we don't have in India, otherwise also the most surgery is very less frequently performed because uh, you know those many repeated intraoperative pathology reports are not all that handy for everybody. So, in case you don't have the option of frozen section, would there be any change in the room of the gap that you would take from the affected to the uh, would there be extra millimeters? Because
So,
considering where I'm practicing,
yeah.
the closest frozen section is not even in the state. So I just would like some insight on that.
No,
So
no, Anuradha is smiling at that because, even though we are in Bombay, we've had our issues in our initial days of practice, because, not everyone is practicing in institutes, or even some of the bigger institutes don't have frozen section. They outsource frozen section. But there is one very interesting thought. I think Dr. Bipasha also speaks about it a lot, where in SN I have heard that they uh, excise the tissue, send it for rapid pathology, rapid histopathological evaluation, patch the patient, and do the reconstruction after a couple of days. Because, in if we remember our basics of teaching, we have been taught that if you repair an eyelid tissue even after 48 hours or 70 or 72 hours, because of the vascularity of the tissue, you can still sort of get very good outcomes for an eyelid reconstruction. So I've seen people who sort of do the reconstruction as a second stage after 2-3 days, rather than excising more margins, because eyelid tissue is as it is so limited. So if you
right,
excise 2-3 millimeters more, sometimes you're left with nothing. So I
right.
don't know, Anuradha would also be able to share her experience, or Dr. Raka might be able to guide us more. Because Dr. Raka practices in an institute, so I don't know whether she has access to frozen section.
Yeah, actually, we have access to frozen section in a way that we send the samples to nearest Apollo hospital.
Yeah.
But all patients cannot afford.
Correct.
So we follow Dr. Bipasha ma'am's procedure. Who sent for a rapid pathology and reconstructor after few days, after we get 4-5 days.
Right.
Next time.
Yeah, Vatsalya, I would sort of agree. So I have operated in different settings. Like I do operate in Thane and Bombay, and I've also operated in second tier towns in northeastern north. So everywhere I have to follow protocol based on the availability. It's not just about frozen section. I feel more than frozen section, it's important to find pathologists who are confident enough to give you a report and the trust that you place. Because especially when you go to a different city, state and operate, your chance of leaving residual tumor, you don't want those sleepless nights.
Right.
So the best part about operating on the face is the vascularity. So even if you take a gap, sort of in those places, I take the traditional pathology, just send it in formalin, wait for a couple of days, and maybe tell them to speed up things a bit. And finally, when it comes, all you need to do is just freshen up the edges and very confidently and calmly go ahead with reconstruction. And I must tell you, there is a different relief when you do it like that.
True, true. I definitely agree to that. So,
So Dr. Raka, would you have anything?
Yeah, Dr. Adit has nicely presented and almost covered all the aspects, but I'd like to ask him whether would you consider the vertical defect while reconstructing with the Cutler beard procedure? Because I have seen that if not enough phonacial conjunctiva is present after excision and we close it with only Cutler beard, there is a high chance of developing post-operative conjunctival shortening and ankyloblepharon after the release of the shared flap. So we prefer for higher defects or more defects vertically, we add with the Cutler beard with something else.
Yes.
Some form of flap plus graft combination superiorly.
Yes.
Because once there is ankyloblepharon with a conjunctival shortening, there will not be lid closure and the corneal keratinization and all sorts of complications will occur. And another thing, the role of tissue expansions. Yeah, because plastic surgeons routinely do tissue expansions, and yes, we have much tissue released and we can avoid much larger procedures if we can expand the tissue, especially laterally. And in Kolkata, RIO, and also sometimes we are also trying a bit with the available tissue expander like a simple silicone balloon catheter, like that only.
Foley's catheter.
Foley's. I don't want to mention the company name, but it's a simple balloon catheter expansion which it can inflate actually. So this will help us, in fact, in the lower lid defect, which I have seen that long-term studies are waiting still, seen that almost 90% defects can be closed by a simple tensils. We can expand the tissue laterally before few days, 3-4 days back, but this procedure has certain disadvantages like 2 sitting surgeries and all.
So, ma'am, for tissue expansion in the lateral area, you means put the catheter through a small cut
Yes.
the temporal.
Yes, that we do. But there are a lot of controversies in this procedure, and
because a lot
still
of
we are
plastic
waiting.
surgeons use tissue expansion for the forehead and
Forehead, yeah. But laterally, if we can use, and the cheapest available material which we have in our hospital is that catheter only.
silicone catheter. Yes.
But the studies are waiting, and is a very controversial thing that we are doing.
So if anyone else has any questions, any comments, or anything that you would like to add before we wind up, most welcome.
Dr. Tinku,
Yeah.
for the students,
Yes.
would you mind if I offer a few tips regarding how to go about studying?
Please
So
do.
I have done my primary DNB from Arvind Eye Hospital, Tirunelveli. So you have to tackle eyelid reconstruction in 2 aspects, one in theory, one in practical. So in theory, you can, of course, look up all the flow sheets and everything, principles, regurgitate it, right? Now, the tricky part is going to be in practical. you will have a patient with an eyelid lesion, and you specifically will have to use your own head. And as soon as you come towards a diagnosis, differential diagnosis, you talk of incision biopsy, then of course the surgery technique, that is where your viva is going to lead. So make sure that you answer those questions, those basics right, that if 25%, 30% of the eyelid is gone, what is it? You have to follow direct closure. Tension is okay in the eyelids horizontally, not vertically. And again, if it is 50 to 60%, which technique and beyond. So that aspect of it should be clear. And one trick to studying eyelid reconstruction is to phase it into 2 days. That one day you study the theory aspect of it. And what you do is next day you take Kansky, go to a senior who does eyelid reconstructions, and you sit with them, open all the pictures of every eyelid which has a certain lesion. Imagine you're going to cut it with 4 millimeter margins, draw the defect with a paper and pen, and you think that what is the surgery that is supposed to be done, cross-check with the senior. So the second day, if you complete your Kansky pictures of eyelid and tumors like that, the principles of eyelid reconstruction are going to be solid in your mind, and you will not have to struggle during your exam.
Good, excellent pointers indeed. So if any other pointers anyone would like to give, if not, we've come to the end of this this webinar. And I thank all the participants, Dr. Adit Gupta, Dr. Vatsalya, Dr. Anuradha, and Dr. Raka Chatterjee for your presence here and your excellent inputs. Thank you so much for sparing time. And for all the audience that is watching, tomorrow we have a very interesting webinar. This is an ARC AIOS webinar in conjunction with the Young Ophthalmologist Society of India. And this would be a series of debates on the evolving techniques in ophthalmology. Also, we'll be presenting summaries of some latest articles from journals. So it promises to be a very interesting session. So do log in at 7 o'clock. It's from 7 to 9 p.m. and hope to see you all there. With that, I again thank all the participants, all the viewers, and bid you all a very good night.
Thank you.
so
Dr.
Thank you so much.
Thank you.
everyone.
Thank you.
Good night, everyone. Bye.
Bye-bye.
Bye.